Well, thank you very much. It's really an honor to be here. I have tremendous respect for the history of spine surgery in Germany, and also thank you, Peter, so much for the kind invitation. We had an opportunity a few years ago to spend some time together at the Charité, and I'm so happy to be back with you today. In the next half an hour, I'm going to describe a bit of a personal journey that I've taken in data, along with the International Spine Study Group, which is the North American registry. Much of that work is in combination with the ESSG, which is the European registry. And I'll try to give you a feeling in the story as to why we had to go in this direction from a research standpoint, and then why later in the story we had to take a bit of a turn. I do have a significant conflict with Medtronic. I do lead their data efforts in their unit and their large data ecosystems, so I did want to call that out. I always like to tell this in the setting really of a personal story, and much like Peter and many of you here, I train a lot of fellows and a lot of young surgeons coming out. And one of the things I always feel is our burden as more senior surgeons is to try to figure out what the playing field for these young surgeons coming out is going to be. What transformations are they going to see in the next decade? In the United States, certainly we're moving to much more ration care models, whether the United States wants to admit that or not. We're going to be in a pay for performance, pay for quality sort of decade coming up. And certainly there's a lot less tolerance than when Peter and I trained for learning curves coming out of fellowship. Much like airline pilots these days, young surgeons coming out, they have to be equally as safe as the more senior surgeon. So we need to put structures and technologies in place to assure that. If we think about this in terms of a public health issue, one of the reasons that adult spinal deformity is so interesting as a model is we see a tremendous growth in it around the world. Much of this is due to an aging population, certainly in the US and Asia, but also it's due to higher expectations for greater health as patients are getting up there in years. However, the care for the adult deformity patient, for the aging patient, is up against a lot of competition. It's up against dementia care, cardiovascular care, and musculoskeletal care, and many of those specialties are doing a much better job. If we look in Asia, a third of Hong Kongers over 80 will have some dementia by 2050. This represents a tremendous simultaneous drain in the healthcare system for dollars and for other currencies that will compete against our ability to offer this sort of sophisticated care to these patients. So therefore, there's really a need for innovation. We recently published, about 2 months ago, what we thought of as really a manufacturing DMAIC process around failure in spine. And we basically categorized every type of failure, and I'll describe some of that in a moment. The reason being that there's so much failure in adult deformity. There's clinical failure. This represents every patient in the North American and European database for adult spinal deformity in the registry. And you see the outcomes are all over the place. We have high rod fracture rates. If we do a deep meta-analysis of the literature, between 10 and 54%. The best study of rod fracture done was an NIH trial, National Institute of Health in the United States. And the 5-year rod fracture rate was close to 40%. And these are scoliosis patients, not PSO patients, interestingly. PJK rates, extremely high. We all know that. It represents really an ongoing cause of failure in these patients. And reoperation rates around 20%. And why is this so significant? Because when you compare adult spinal deformity reoperation rates, they're on the level of AAA repair, free flaps, very precarious types of complex procedures, and they're so much higher than other types of procedures that are competing for those healthcare dollars, like arthroplasty, for example. They're doing a tremendous job. They're not reoperating on many of those patients, and yet in complex adult deformity care, we have a 20% reoperation rate. This reoperation completely destroys our cost effectiveness. We reoperate on patients within a 10-year period. Our ICER ratios go through the roof, over $300,000 in 3 years. We only start to approach what would be considered a reasonable ICER ratio at 10 years if these patients have not had surgery again of 80,000. Usually the threshold for determining whether an intervention is cost effective at the level of policymakers is around 75,000 in the US anyway. So that failure destroys the cost effectiveness. So how have we gone in the US to prevent failure? Well, we've spent more money. So we're actually, during these surgeries, we're doing double pelvis, double rods, VCR rod, BMP2, ligament repair, 2 surgeons, plastic surgery. So to try to prevent reoperation, we're spending a lot more money at the index surgery. And you know what? We're still not preventing it. So we still have a significant issue. So we have to come together, not just as spine surgeons, but let's just think of ourselves really as a community. We're going to have to come together with our industry partners and try to figure out what we're going to do. Now let's take a step back on the implant side, something that's easy to monetize. So how much do we think in the last 10 years, if we're honest, that multi-axial screw innovation, and many of us in the room are on these projects, has really moved the needle in terms of our outcomes and safety? And then we have these huge corporate partners, Medtronic and Johnson & Johnson, just to name 2 of them, that are huge freighter ships that move very slowly in trying to navigate innovation. Historically, this has been a real problem. So we're now asking them, and they're admitting, they realize this is the issue. They need to move from implant companies to data companies that also make implants that address needs. In order to do that, in the US, they're going to have to adjust the sales teams from relationship-based teams to teams based on technology, technologists, engineers, not people with good social skills so much, but people that have much more technological skill in placing them in the operating room. They call this going through the belly of the fish at Medtronic anyway. They're already anticipating there's going to be a drop in revenue as they move through this data transition period, for example. Well, one way we could improve is we just say, Peter, you just need to get better. You need to train the next generation of surgeons and make them better than you. But if we're really honest, nowadays, do we really think the next generation of surgeon is just going to be that much technically more superior to us these days, to the guys that are really at the forefront of technological surgery, that they're going to be that much more facile with their hands? That's probably not a solution, right? So one thing we can do is to create better enabling technology. And one type of enabling technology is navigation. It's used all the time in transitioning the taxi industry into the Uber industry. I took an Uber here this morning, and it's made the experienced or the inexperienced Uber driver just as safe and just as accurate as the much more experienced driver. This is very much like the example of Dr. Lenke. When he first came out of training, he had a magical power. His magical power was he could place pedicle screws freehand better than anybody else. With the introduction of navigation, that magical power went away. The playing field was completely leveled, and he sort of reinvented himself, as he would admit, and moved into VCR and things like this that continued to try to differentiate him from the other masses of surgeons. So we have to really start to, if we're going to make this move and transition as a specialty, to try to continue to make these surgery cost effective, to try to eliminate the variability that's going to be the downfall of our specialty, especially in complex spine care, we have to go about analyzing this in the right way, not just asking the right questions, but asking them in the right way. One way to think about it, and this is a patient actually wrote me this note about 2 years ago, or 2 months ago, and said, "You're God's manufacturing process, or God's factory, spine factory on earth." And this got me thinking, and many of us are also going to business school these days as spine surgeons. It got me thinking, could we apply a typical manufacturing optimization strategy, something called DMAIC, to the process of adult deformity care, and try to figure out how data and really analyzing our products could help to move the field forward. In a sense, we really are manufacturing spines, and 20% of those complex spines that we're manufacturing are failing. So if you were the CEO of US spine manufacturing, if there were such an unenviable job, you would say, hey, we really have a problem. We are not doing a good job off the assembly line. 20% of these are failing. So we have to define the problem, and then institute different and better ways to measure and analyze it. And then we have to improve and control that process of improvement. And this is where I think data is going to make such a huge difference for us. So now I'm going to show you how I think leveraging the power of big data in various different ways is going to be our salvation in many of these areas. So it's going to help us with benchmarking. It's going to help to eliminate human bias and human error. It's going to help us with figuring out what are our missing pieces of information, and then how important is this biological variation, which is thus far not measured very well. And then how do we implement this controlled loop improvement process, which is so common in manufacturing, where every 5 to 10 implants that come off the line, they're reanalyzed, right, to see how close they are to the standard. We're not really doing that as surgeons that are manufacturing spines. So one of the common problems that we have in the United States is how to measure quality. We have to figure out a way to do what we call benchmarking. And one example of this is to look at proximal junctional failure rates. It's a very common mechanism of failure in adult deformity. And the way we've done it in the past, and the way that many hospitals do this for various things, it could be readmission after elective aneurysm surgery, for example. It doesn't matter, it doesn't have to be spine surgery, is they take a very simplistic averaging across different surgeons or different sites. So the numbers you see there are every site in the North American registry. And you see a lot of variation in the rates of proximal junctional failure, right? You see some sites that have very high rates and some sites that have much lower rates. And the way that this was done in the past was just to draw that average rate across and say, okay, if you're over that line, you're an underperformer, and if you're under the line, you're doing a great job. Well, if we apply predictive modeling that takes into account more than 50 different variables, that actually goes to the root of the issue, which is frailty, osteoporosis, the complexity of the procedures these patients are having, how old they are, and essentially applies multivariate leveling to the playing field, we see that some of the sites that were actually under the line that seemed to be doing a good job were actually doing a poor job. And some of the sites that had very high rates were just treating more complicated patients and doing more complicated procedures. The only way to do this accurately is with sophisticated predictive models that are built out of these large data sets. Another way that we can start to leverage the power of data is to try to bring the experience of treating 10,000 patients or 100,000 patients. Imagine someone like Peter at the end of his career, or Jürgen Harms at the end of their careers, how much judgment they have because of how many patients that they've seen, how many patients they've treated. In an individual career, you can only touch so many patients. But through data, you can actually touch 10,000, 100,000 patients and have the knowledge of how those patients were treated. So again, to make this more individual, when my fellows email me or text me about cases, and I'd ask you to think in your own mind, what happens to you when you graduate people and how they recontact you. It's usually not how to do it, right? We've done a pretty good job of teaching them how to do the surgery. It's usually what to do, whether they'll actually get better if you do it, is it worth doing it, what's the risk of that, and how do we take a product and put it in the operating room or put it in the hands of these younger surgeons that will allow them to sort of equalize this safety much earlier in their careers. So one way to shorten that judgment learning curve is to apply more sophisticated data techniques. One of the most interesting techniques is something called unsupervised clustering. And what this does, it's a machine learning strategy, is it identifies patterns in your patients that are impossible for you to recognize. It's based on 20, 30, 50 different variables, some cases more than 100 variables. This is actually used quite commonly in medicine. If you read Lancet or New England Journal, they're re-looking at a lot of old questions that they thought were previously answered using standard techniques, and they're taking a fresh look at them using these types of sophisticated data techniques. This is just a recent study from Lancet in 2021 where they reanalyzed the impact of beta blockade and atrial fibrillation in heart failure. Previously was felt to be completely ineffective. But what they did, they went back and they found certain clusters of patients in which it was highly effective. So if you used traditional techniques, you would have missed that. So we applied unsupervised clustering, which is where the computer just goes in, looks at your data, and says you have this many different types of patients and this many different types of surgeries. And we developed a risk and benefit classification for adult deformity that we published actually based on clustering. It gives you in real time the risk and benefit of an operation prior to ever pulling the trigger. But this is where I think it's even more interesting. So rather than just taking that 50,000-foot view and the patient in front of you belongs to a certain group and you get a risk and benefit, what it actually does is transforms the way that young surgeons may see the patient. So on the left is how they might look at an individual patient. They're pretty sophisticated. You've taught them well. They're looking at various radiographic criteria. They're measuring things. They're looking at the x-rays. But on the right is how the machine looks at the patient. It says, this is you, this individual patient, surrounded by the 10 patients that are most similar to you. And then this is how they were treated around the world. It actually applies a basic, sophisticated, like fingerprint matching strategy. It says this patient in front of you, based upon these 50 variables or these 100 variables, and this will grow over time, this is how this patient did. This is how this patient was treated in Germany. This is how this patient was treated in the United States. Nearly this exact patient done through fingerprint matching, X-ray matching, frailty matching, osteoporosis matching, activity matching, in the future genetics matching, telomere matching potentially. And that's what's going to take, I think, the young surgeon and make that surgeon level that playing field. But potentially the most interesting area is what I call tier 3 enabling technology. And that's where you take the fighter pilot level surgeon, the master, somebody like Dr. Lanke or Peter, and you give them technology that's going to make them better. Think about what a challenge that is, for industry, to come up with something that's going to make even the master surgeon better. So you can actually even improve the judgment of the master surgeon by improving his decision-making capability, by eliminating noise. And I think even the more senior surgeons would admit we all have bias, which is probably present in our decision-making. We maybe had one last case that went poorly. We think we'll never do that again. Well, you can actually study decision-making. It's one of the more interesting areas to apply to surgery. One of the greatest books on this is Thinking in Bets. It's about poker and bet-making in poker. One of the most interesting errors for the surgeon is something called resulting. And that's where we take the quality of the outcome and we say that implies something about the quality of the decision. So in poker, if you make a bet, a great bet, and you lose, you should probably make that same bet again, right? If it was based on the right information, that's the key. If it was based on the right information, you should make that same bet again, even though you lost. But as surgeons, if we operate on someone and it turns out poorly, we often make huge paradigm shifts in how we treat that type of patient in the future. That's an error of judgment. That is not correct decision making. How do surgeons do when they make decisions on these complex patients? Well, just imagine you're a young fellow calling the ESSG and the ISSG surgeons and saying, I have this patient in front of me, call it case 7. What is the likely complication rate at 2 years? And you see a range of that the surgeons would quote that young fellow. Oh, I think it's either 1 or it's 100. These are actual answers that we got from the surgeons in the group when we gave them cases and said, estimate the complication rate at 2 years. Some of these very senior surgeons said it's non-existent, and some said 100%. So this is not providing valuable information at the point of care. When we compare the machine to the surgeon, we see that actually the machine and surgeon don't agree many times on what would be the risk or outcome. And when we measure and validate the predictive models that we've created, we see that the predictive models are usually right on. They've validated many times now, this 3 or 4 published studies of validation of our predictive models. So the first model that we created in conjunction with the ESSG was around complication. And we said we could predict between 65 and 80% accurately the risk of complication between every time point between 2 days after surgery and 2 years. 2 days was interesting because you can determine, does that patient need to go to the ICU? 2 years is interesting because humans, Homo sapiens, are actually best at estimating risk that's immediate. We're very poor at estimating risk that's farther out in time. It probably has to do with the way we developed our risk assessments in our brains from primitive times. We also developed predictive models of outcome, where we could predict every major instrument, ODI, SRS-22, at every time point at 1 and 2 years after surgery. So rather than quoting someone an average value based upon 50 to 100 different variables, depending on the model that we look at, we're giving them a precise calculation of them having that patient in front of you, having that operation with that surgeon. And we published many of these models. So here's how it works. We first cluster the patient. That allows the fingerprint matching that I showed you. We then enter a bunch of different demographic and radiographic and baseline information. And then we can predict in real time the risk of reoperation, readmission, major complication, the outcomes out to 2 years. So let's take a look at a few of the things that this gives us. So one is it gives us the ability to predict QALY, right? Because we can actually transform SF-36 into QALY. If we compare operating according to what the machine recommended versus what the surgeons actually did, so we let the machine basically determine, this is a simulation analysis, but we essentially let the machine determine which patients we would operate on. We had a 684% increase in QALYs gained per patient compared to the surgeon decision-making for the patients. So anyone that doesn't think machine learning or AI is coming to the surgical decision-making process, I think we're fooling ourselves. It also allows us to do something like this, where we can apply this at the population level. Think about the NHS, for example. NHS can go in and say, we're gonna require this likelihood of reaching MCID, and we're gonna not allow surgery that has this high a complication rate. What that does in the United States is if we set a 50-50 filter according to 2019 numbers in the US, we would reduce the spend on surgery that had high complication and poor outcomes by $500 million US dollars. Well, we can move beyond risk and benefit, and we can actually apply predictive modeling in other areas in machine learning, one of which is in the sagittal plane. So I think we're all learning over the last several years, and this is from one of our NAS papers this year. We show that the SVA at 2 years actually has very little correlation to the 2-year ODI, less than 10%. So actually the intimate correlation between sagittal realignment and a certain disability score has really gone away. And what we're seeing is it's much more linked to risk of mechanical complication. When humans try to bend rods without the assistance of machines, we see a tremendous variation, actually more than 20 degrees many times, even with experienced surgeons contouring rods to specific angles. What does this mean? Well, if you have a 16-degree error in your bend, you can have a 9-centimeter SVA difference, which can then lead to that patient having a much higher reoperation rate. Humans are not good at processing more than 5 bits of information at a single time, so it's very difficult for us to calculate in our minds how we should bend that rod based upon how that patient is going to equilibrate when they stand up. Well, what's the solution? Well, how about rod bends that are based on more than 10,000 patients? So you can actually build databases of how patients reciprocally realigned in their unfused segments and then compensate for that in the rod planning and rod bending, and this is something that's not possible for humans. When we did this at UCSF, we decreased our malalignment rates by about 21%. We also, though, are missing data, and this is going to be, missing data is now the subject of the rest of the talk. Some of the data we're missing is actually force-related information. We don't have the ability, we're very good at architectural planning, right? So we use Surgeon Map, we use some of these other strategies, you use some of the vendor strategies or whatever to calculate your realignments. But you have no way, you don't go then and apply engineering data to that X-ray and say this plan results in this force on this rod, and you don't have any really way of assessing that. So there are a lot of startup companies now that are trying to build what are called digital twins, where they're going to not only, where you're going to architecturally plan the surgery, and then this digital twin is going to allow simulation of what the forces are at various parts of the construct, and whether you're going to be underneath the endurance limit of the UIV, for example, to prevent a fracture, or underneath the endurance limit of the rod to prevent a rod fracture at certain areas. And we know for sure we're missing gait information. We're not building static structures, we're building dynamic structures. So until we start to include force data and torso movement, we're going to be missing a huge part of this as well. So we're going to move from very simplistic assessment of realignment, which is usually like one radiomics type feature, to data loops that look at 100 different radiographic features at once, see how we realign the patient, see what complications they have, and then optimize this process over time. And this is the control aspect that I was talking about before. And to me, next, in the last 5 minutes, this is the most exciting area in which we're currently engaged. What we realized in 2020 was when we added another 500 patients, and then we did this again in 2021, we added another then it was actually 650 patients to the combined registry. We did not see an increase in accuracy in our predictive models like we anticipated. And what did this tell us? Because we're collecting more than 1,000 different data points per patient already. It told us we were missing probably some very important information. We categorize these as known unknowns, things like gait, we know about that, and unknown unknowns, things that we can't yet figure out what's going to be important and how do we protect our database from that. So what's missing? Well, physical phenotyping is missing, walking speed, muscle bulk and sarcopenic assessment, the muscle strength, actual strength testing, not just a subjective physician grading of strength, but actually a physical assessment of the patient's sarcopenic state. What about physical data versus traditional subjectively reported disability data? Well, the ODI has no correlation at all to sit-to-stand times. So you look at across each ODI decile, you would think disability would be correlated to the ability to stand up, no relationship. SRS activity, no relationship to 4-meter walk. So how they're reporting their walking is very different from how they're actually walking. Another problem with our data is it's static. It's just single time point data where we're not measuring variation. What we want to do is try to build what's called an integrated health state for these patients. So their level of activity over time. And the best way to do that is through real-time physical activity monitoring, which is another huge hole in our data sets. We also are moving into quantitating how patients are aging differentially. One way that patients age is some patients actually become more inflamed as they age. This leads to cardiovascular disease. It leads to lower fusion rates. We, this year, analyzed CRP in our adult deformity population and found it was linked to risk of major complication. We also realized that we're missing a lot of telomeric data, epigenetic information, and metabolism information. And so we've moved into this area very hard. We started a study a few years ago on differential aging using telomeres. This won the Hibbs Award in 2021. It was just published this month in JNS Spine. There was no correlation between genetic age and chronological age. But patients that had the shortest telomeres had a 26 times increased risk of major complication. This was our single most important variable when we started to add this back into the predictive models. Another area that's quite interesting for us is epigenetics, measured through methylation. There are a lot of commercially available methylation clocks of aging. We analyzed 7 of these in a collaboration with a company called TrueAge, which actually got its start in predicting racehorse performance. It's kind of interesting. And we found that for the first time a blood biomarker of frailty. It's a methylation epigenetic clock called Dunedin pace. Also interestingly, epigenetic aging is not linked to disability. So disability is a separate phenotypic expression not related to epigenetic age. What are we doing in the future? Well, we're going to go back and add these variables back into the clustering algorithms and see whether we are able to differentiate many additional different types of patients. The literature on aging seems to indicate that composite scores that include telomeric information, methylation information, metabolomics information is much more accurate in predicting risk and lifespan than singular information. So again, we're trying to add additional things like metabolic information. And one of the things that we're really doing at scale now is we're trying to create a tissue bank. This is where we're going to address the unknown unknowns. We're basically putting this tissue away so we can study it in the future. This is a new collaboration that we have with AUK, Hopkins, WashU, and ESSG. You can see all the different tissues that we're going to study there. And this really comes from the current modern reality of datafied cancer care. Where at my institution now, when we take a specimen like this chordoma, this goes through something called the UCSF 500 panel, where it's not just looked at histologically. All these different mutations are measured. And not just the different mutations in the tumor, but the patient undergoes whole genome sequencing. So you can look at the tumor within the host. And this is where we think we're going to get much better. So initially I showed you all those different failure rates. Well, what's going on in cancer is they're doing epigenetic and genetic profiling of patients and then tailoring the precision care to that patient's given genetics. This is exactly what we want to do in spine surgery so we can have better outcomes. We want to datafy the bone and study the fusion host, not just study the fusion cocktail itself, but actually the host constituents of this. But we're going to reach something which I like to call the randomness limit. Even if once we add 100 different variables or 200 more variables, genetics, epigenetics, metabolomics, whatever, we're still going to reach a level of randomness that we can't get beyond because we're playing poker that involves some aspect of luck and randomness, not chess. This is going to be us in the foreseeable future, and so the last slide I want to show you is we have a lot of work to do. And much of our focus right now, both at UCSF, ISSG, ESSG, as well as with industry, is trying to make all this new data digestible and usable at the point of care for better point of care decision making. It's very much like the Bloomberg terminal, which is used on Wall Street. Why was Michael Bloomberg so successful? Because he made a terminal that displayed the user experience and user interface, the most important data for decision making in a digestible way so the traders could use it. So we need to do the same for patients and surgeons at the point of care to enable better decisions. Thanks very much for your attention.